order. And thank you very much, everybody, for being here. We're going to continue on our study for in the Act, an Act providing for the development of a framework for palliative care in Canada. And I think we're all very interested in this and all very supportive. So we welcome the testimony and our witnesses today. We look forward to your presentations. On panel one, we have the Canadian Hospice Palliative Care Association, Sharon Baxter as Executive Director, accompanied by the Canadian Nurses Association, Josette Rossell, Senior Nurse Advisor, and each has 10 minutes to start, and if you could keep it tighter, that gives us more time for questions. So thanks very much, and whoever wants to go first.
Okay, we actually already tossed for the coins, and I'm going to go first. So first, let me thank you for allowing us to present this afternoon, or this morning, I guess it's still morning, and thank you to Member of Parliament Marilyn Gladue for putting the motion forward. We're thrilled to be able to present today. The Canadian Hospice Palliative Care Association is the national association that provides leadership in hospice palliative care in Canada in the pursuit of excellence for the care of the persons that are approaching death, so that the burden of suffering, loneliness, and grief are lessened. Hospice palliative care is aimed at the relief of suffering and improving the quality of life for persons who are living with and dying from advanced illness or bereaved. I noticed in the motion that there was a question about the definition. There are a number of definitions, so if you refer to the brief that we've submitted, on the last page we actually gave you the definition of hospice palliative care, palliative approach to care, and advanced care planning, because of course they all sort of get intertwined in people's thinking, so hopefully that'll be helpful for you. We are obviously pleased that there is a desire to develop and implement a framework designed to guarantee all Canadians have access to high-quality palliative care. The provision of specialist hospice palliative care is often in acute care hospitals or residential hospices, and the palliative approach to care provides care in the community that looks at home care, long-term care, and other settings, but both have not received the attention, the funding, or the support that they've needed, and in light of our aging population, it's going to become a critical issue. Now, if I may, I'd like to take the time that I have to highlight some of the existing resources and documentation that could help you in developing and implementing palliative care framework. To be clear, we're not starting from scratch. We have a lot of information. There's been a lot of reports. CHPCA, my association, serves as the Secretariat for the Quality End-of-Life Care Coalition of Canada that was formed in 2000, so we've been around for 17 years. And I'd like to have a quick shout out to a few of the coalition members that are in the room today. CNA are here, the Pallium Canada, the Canadian Cancer Society, and the Canadian Society for Palliative Care Physicians are in the room today. But there's 39 national associations, including all the professional associations and disease-specific groups. And they've been working together for 17 years to try to highlight the issue of hospice palliative care. At the end of our brief, we've also listed the coalition members just for your information, because obviously we don't want to take up the time today. The Quality End-of-Life Care Coalition produced a guiding document called the Blueprint for Action 2010 to 2020, and it identified 4 priority areas of focus, and they stand the test of time through the last decade. The first one is ensuring all Canadians have access to high-quality hospice, palliative, and end-of-life care. The second is providing more support for family caregivers, including bereavement support through the federal compassionate care benefit and other opportunities. We actually have about 6 or 7 different ideas. Improving the quality and consistency of hospice palliative care in Canada, including research, training, and education, and encourage Canadians to discuss their wishes for their care in the future, including at end of life. We've often referred to this as advanced care planning. Called different things depending on where you are in Canada. It's so Canadian that different jurisdictions call it different things. Between 2012 and 2015, the Government of Canada provided CHPCA and the Quality End-of-Life Care Coalition funding for a 3-year initiative called The Way Forward. an integrated palliative approach to care that culminated in the development of a national framework and the dissemination of practical resources and tools to help governments, policymakers, regional planners, health service organizations, and healthcare providers on the ground to adopt a palliative approach to care. And indeed, 5 provinces are using it as a foundational piece of work in trying to push out an integrated model. The Way Forward was intended to be a catalyst for action by raising the awareness and understanding of a palliative approach to care. The Way Forward initiative also defined what hospice palliative care and a palliative approach to care and advanced care planning are. I'd refer you to the lexicon of terms. Again, at the end of our brief, we've put some links to some of these documents, and in the Way Forward, we have a lexicon of terms, so hopefully that will help you with your deliberations. Traditionally, the last days or weeks of life are the most common time for referrals to hospice palliative care programs and services, if at all, and are often reserved to individuals designated as dying. And that tends to be the patient that is dying with a end-of-life experience that needs specialist care, so cancer patients, HIV or AIDS, or some of those diseases, but not necessarily those patients that are not designated as dying, like the dementia patient. So indeed, about 65% of Canadians die of diseases that do not need a specialist care palliative care necessarily, but need a palliative approach to care. So there's this nuance between the two. The overarching goal of the initiative was to ensure more Canadians can live well until dying by enhancing their quality of life through the course of illness and through the process of aging, and not just in the last days or weeks of life. In December 2016, so just 2 months ago, CHPCA undertook an environmental scan of all the provinces and territories, as well as the QALCC members, to determine where they stood in the implementation of a palliative approach to care. Given that health is a provincial and territorial responsibility, it is absolutely imperative to understand where their priorities lie best to determine how we proceed federally. The survey provided important information that will drive the adoption of a palliative approach to care. Remember, the initial project was only $3 million. It was a catalyst project, so it was just the start of the conversation. So the 5 areas, the 2 surveys offered the following highlights, and I'll just name a few of them. While public awareness is one driver of adoption of a palliative approach to care, it is more to do. We need to do more to enhance the understanding of a palliative approach to care and advanced care planning with the public and healthcare providers. I think the public is an interesting piece of work that we really need to do. Most Canadians are confused about what hospice palliative care is, a palliative approach, what's do not resuscitate, what's sedation, what's MAID, what's do not resuscitate, what's your rights between hydration, nutrition, and treatment. It's all blurry in Canadians' minds, and we really need to do a much better job of giving them that information. National education curriculum and ongoing continual professional development through enhanced skills and training are needed for all healthcare providers across all settings of care. Conversations about the palliative approach need to be better integrated in the usual medical care. This would help to make a palliative approach part of ongoing treatment and not necessarily a separate specialized or referral-based program, so it becomes part of the care that anybody will receive when they're coming to the end of their lives. Ongoing advocacy efforts for a palliative approach to care must continue, particularly in light of the introduction of medical assistance in dying, which has created a need to clarify what hospice palliative care is all about and what is available and what more needs to be done to ensure that it's accessible to all Canadians. We've often said it would be a shame if a Canadian chose MAID when they could have benefited from hospice palliative care, so we need to be able to make sure that they're given that opportunity. Current care pathways need to include a palliative approach and tools and materials for the healthcare system, and professionals must ensure adoption. We must ensure resources are available and dedicated to hospice palliative care and flexible to meet population health needs, including those Canadians that are members of the Indigenous cultural vulnerable groups. This final report was given to Health Canada just on Tuesday. There are other several great reports, studies, environmental scans, and evidence that have like the recent consensus statement and lay panel recommendations coming out of the November 2016. You can see a lot of this is just very recent. 3-day Palliative Care Matters consensus conference that was held here in Ottawa. All findings are consistent with the Blueprint for Action and many of the other reports, and they called for a national care strategy, a national secretariat, including a national center for research, a national public awareness campaign regarding the palliative approach to care and advanced care planning for the public and healthcare providers, education and training for professional and healthcare professionals and caregiver supports. So as you can see, there's a great consensus between all these studies. I noticed that Bill C-277 referenced all Canadians, and it is imperative that policymakers remember that not all Canadians have equal access to health care, especially hospice palliative care in this country. Vulnerable populations, including Indigenous, disabled, homeless, or vulnerably housed, impoverished, or incarcerated, are often forgotten. Innovative models for delivering hospice palliative care are required to meet these populations' unique needs and to address the barrier that they face when accessing services. Barriers to accessing high-quality palliative care include non-malignant diagnosis, geography. We do a much worse job providing services to rural Canada. Poverty, lack of supports, comorbidities, mental health, and substance abuse all play into how these people do not receive the care that they need at the end of their lives. So when you say all Canadians, we really need to think about all Canadians. And the last group, I'm almost finished. Another group who are often not considered are children. A recent study from Sick Kids in Toronto that was finished in 2012 cited that overall only 18.6% of deceased children who might have benefited from palliative care received the care based on their diagnosis, and 25.2% had their care only 8 days before they died. We can do much better. Pediatric palliative care has developed as an integrated model of care and can successfully be adopted by in the adult population. We can learn from their experience. In summary, we really don't need to study the situation any further. The studies and the reports have all been done. The ample evidence clearly points to one course of action, which is to support and fund for the agreed upon priorities to make hospice palliative care accessible to all Canadians. Governments and healthcare associations and organizations have all been partners in this, but corporate Canada has a role to play. The Canadian Hospice Palliative Care Association, my association, has a Champions Council, which is made up of leaders of industry and commerce. And they've just launched a program called Canadian Compassionate Companies, which highlights companies and organizations that accommodate and
I'm sorry, Ms. Baxter, but we have to move along. But thanks.
All right, and just finish the sentence, and that support caregivers at the end of their lives within the workplace. And that was it. That was it.
Well, thanks very much. I'm sorry to end it, but we have to move. So, okay, Ms. Frizzell.
Thank you, Mr. Chair. My name is Josette Roussel, and I'm a registered nurse and senior nurse advisor for the Canadian Nurses Association, the national professional voice representing nearly 139,000 RNs and nurse practitioners, including almost 1,400 nurses with specialty certification in hospice palliative care. Nurses are leaders with a fundamental role in developing and implementing a palliative approach to care. As such, I'm pleased to inform the committee that CNA is supportive of this important bill. I will now turn into CNA's 4 suggestions, including several amendments for the committee's consideration. These are outlined in detail in the brief that we will submit to the committee. First, the need for greater emphasis on a palliative approach to care through the bill. CNA advocates for a palliative approach to care enabled by advanced care planning. This approach is guided by core tenets of palliative care, such as dignity, hope, comfort, quality of life, and relief of suffering. This care is provided earlier in the course of the illness, in all health settings, by a range of healthcare professionals, and involves physical, psychological, social, and spiritual care. CNA believes that the proposed bill must speak to the palliative approach to care, as opposed to limiting the discussion to specific service provided in the patient's final days. We therefore recommend that Clause A under Section 2-1 be as follows, quote, defines what palliative care and a palliative approach to care is. Secondly, we suggest expanding palliative care training and education beyond specialized palliative care providers. Research reveals our country does not have adequate palliative care training for healthcare providers. One way to address this gap would be to include education and training into the core curricula for students in all healthcare disciplines. We therefore recommend that Clause B be amended as follows, quote, identifies the palliative care training and education needs of palliative care healthcare providers as well as other healthcare providers. Thirdly, CNA encourages the committee to support the development and implementation of national evidence-based standards for integrated palliative care. Currently, there are no nationwide policies and evidence-based standards of care to ensure integration of the palliative approach to care across the continuum. In addition to not having a framework for palliative care, there are no standardized and widely adopted method to guide healthcare providers, including nurses, on when and how to implement a palliative approach to care. The lack of national evidence-based standards for integrated palliative care renders it impossible to collect relevant data and track and report on key indicators. Therefore, the provinces and territories have limited capability to understand whether, where, and how to improve palliative care. Therefore, CNA recommends Clause D be amended as follows, quote, collects standards from research and data on palliative care. Finally, I'd like to address the provision of funding to develop a framework for palliative care in Canada. CNA supports the recommendations outlined in the 2015 Quality End-of-Life Care Coalition of Canada report titled The Way Forward. The coalition calls for federal funding for establishment of a national secretariat that would oversee development, implementation, and maintenance of a national palliative care framework. This would set strategic directions and lead a coordinated, comprehensive, pan-Canadian approach to palliative care. Reinstatement of the Health Canada Secretariat of Palliative End-of-Life Care is a move that CNA would support. In closing, I emphasize that CNA is a strong advocate for high-quality palliative care that is accessible to all Canadians in settings that best suit their care needs. I would like to thank the committee for providing CNA with the opportunity to speak on behalf of RNs and NPs in Canada on this important matter, and I look forward to your questions.
We'd like to thank you both for coming. So now we're going to start our first round of 7-minute questions. We're going to start with Mr. Oliver.
With respect to the questioning, just a brief conversation with the clerk here. Are we only required, is it just one round of 7 minutes, or are we going with what we usually do? Is it 2 rounds of 7 minutes?
5 minutes for the second round.
Okay, so it's just
It's normal.
normal, okay. I don't know what
That's right.
you're referring to then.
We're going to have to do it. All right, Mr. Oliver, go ahead.
Great. Thank you very much. And thank you very much for coming and providing your testimony today. It's very much appreciated. And I think I can probably speak for myself, and I'm sure most around this table, I think there's a real appreciation of the need for a palliative care framework in Canada. In fact, as we've introduced medical assistance in dying, and if you want to call that a choice, if there is no other choice, if there isn't a good palliative care, robust system to support people, then are we really providing a choice for them? So it's important that Canadians and their families do have access to this. And like we all have our own personal stories as well of very difficult end-of-life circumstances that we've had to work through. So thank you for coming. So so I'm highly supportive of the bill. I did want to thank MP Gladue for her work on this one and bringing it forward to our attention. My comments are only meant to be helpful and trying to making sure that we have one shot at this. Let's get it right. So the first one is most of my questions are going to be dealing with the sort of A to F under the framework on palliative care. So the first one is defining what palliative care is. Do you think, Sharon, you had introduced, I think it was a hospice palliative care definition. And generally, I think people turn to the WHO definition of palliative care. So I guess for both of you, is there going to be any controversy in deciding what the definition of palliative care is? And does hospice have a different view than the WHO? Because yours is different than what WHO has.
So the World Health Association or organization put out a definition based on a worldwide model. And in Canada, unlike the US, we've taken a different perspective on specialist care, palliative care. We don't differentiate between hospice care and palliative care in Canada like they do in the US. And some of that was driven by the US having a hospice benefit, and we don't have that in Canada. So when we talk about hospice palliative care, or just palliative care, you can drop the hospice, it's what we refer to as specialist care, the stuff that happens around in acute care hospitals, usually with intense pain and symptom management, that type of thing. This palliative approach to care came out of a movement in Australia to actually try to, it's not the specialist care, palliative care. You know, my grandmother, who was 93, who had dementia and was sick for 7 years, never took a pill. She physically was very healthy, except for her mental mental situation. So she needed what we call a palliative approach to care. There shouldn't be, even within Canada, there's different jargon and different rules around advanced care planning in this. I don't think there's going to be conflict. It'll be interesting. The three definitions we've given you are the ones that we used in the Way Forward project that seem to get a lot of support, so it should be fine.
And may I come? I think with the coalition, we did agree on the definitions around palliative care and the palliative approach to care. It's important to emphasize the palliative approach to care, as it does mean reaching out to a larger number of individuals earlier in the system, so that you have a clearer plan in place for later on. But both are needed. It's just a new concept, and a concept that's not well understood, but that's very important in reality because of our contextual piece in the healthcare system.
And to me, palliative care can occur in a hospital, it can occur in a hospice, it can occur in home.
Of course.
It's really attempting to be responsive to the needs of the patient and the family around them, as long as you can manage things like other complications and pain management with it. So my second question then is sort of around that, and it's making sure that we have the words right on healthcare providers, palliative healthcare providers, and supporting palliative caregivers. So there is no term palliative healthcare provider. We have healthcare providers who are providing palliation. We have caregivers who are providing palliation. And I'm assuming that we'd want to make sure that we've identified the training and the educational needs of both healthcare providers and caregivers. That there would be training even for volunteers, there would be palliative care training, right?
So right now, there are about 35,000 Canadians that are volunteers at hospice palliative care programs in this country, and it's a loose number because there's no one database on that. But it's considerable. They take the training through the hospice palliative care programs. As we push out this palliative approach to care, we really need to start to talk to all Canadians. And when you bring this up, it's really, really important. We haven't got our heads around what that really means.
So just speaking with the words then, like being a bit more focused here. So it says identify the palliative care training and education needs of, and I think, Josette, your wording was of palliative healthcare providers and other healthcare providers, was
Correct.
your proposed amendment?
I wanted,
Which confused me because there is no palliative healthcare providers. So we're either training and educating healthcare providers.
we were suggesting a broader term to reach out other healthcare providers
Of all healthcare
of all
providers.
health
Yeah.
providers that will benefit from training in light of the previous discussion around palliative approach to care.
And for you, is healthcare provider broad enough, or do you think we should be adding and caregivers in there? Or
It's important to highlight the caregivers as well.
so in the proposed legislation, it says identify measures to support palliative caregivers. That's the third clause. Is that sufficient for sort of non-registered healthcare providers?
We saw that one as sufficient.
That's sufficient?
Yes.
And Sharon, are you comfortable with that?
Yeah, I just need to mention that the training for healthcare providers and caregivers is totally different, right? It's not the same type of training, but they're both really important.
Sorry, say that again?
The training that we would provide for healthcare providers and the providers that provide hospice palliative and palliative approach care is totally a different training model than what you would provide for caregivers that are helping care for those that are dying. It's different, and we actually have some models in this country. So somehow we have to get the language so that it's clearly there. They're both very important, but they're different.
Okay, because it struck me, out of 77,000 physicians, there was a report that said there were only 51 palliative care specialists and only 123 family docs that had training in palliative care, and out of 360,000 RNs, 101,348 have certification in palliative care. So my sense is we need to do broad training of healthcare providers, and I'm sure other categories there as well. And the last question I have is, going back to the definition, is when does palliation end? I've heard from some families, particularly that have come through hospices, that they've had tremendous support through death, but as soon as death occurs, they're done. The bereavement and the closure for the families with the caregivers that were side by side with them through the death of a loved one, it's an abrupt loss. Are you aware of any models that extend palliation to some kind of closure or bereavement process for families?
So the existing hospice palliative care programs spend a lot of time on bereavement and actually try to carry the bereavement past the point of death. But they're not funded within the healthcare system, so they're done by those programs, and they're not done for the programs that aren't doing it. One of the things that you can do really quickly is, and we've asked the compassionate care benefit and the federal benefit that we all have endorsed, that the benefit ends the day that your family member dies, and we've asked for them to extend it for a period of 2 weeks. It really doesn't, it makes sense, right? That and so they're looking into it. We heard that they took our repeated letters seriously, and they're going to look into it. We have to pay attention to bereavement. When you don't do this service well and you don't provide support to family members that are bereaved, they end up in the healthcare system themselves. So it's very important. Thank you for asking the question about bereavement.
Thank you.
Mr. Weber, I understand you're splitting your time with Dr. Carey?
Again, Mr.
We're
Chair.
going to one round.
One round now. Can I just have a little bit of a rave, a rant here for a minute? We've got probably the top experts on palliative care in Canada here presenting to us, and we've had to cut Sharon off of her presentation, and now we're only going to give them 7 minutes each to present to us. I find that disappointing, and you try to shorten down our study here on palliative care by limiting witnesses and cutting down presentations, and to me, I just think we're not doing a thorough study by doing that. So I'm just disappointed, and I wanted to express that, and now I feel better expressing that. So perfect. Okay.
We'll start your time now.
So I'm still raving here, Mr.
Still
Chair.
raving.
I just need clarification then. We've got 7 minutes for the Conservatives to ask questions, and that's all.
We have two panels. We can't get through everything if we do 4 panels altogether.
Why are we doing so many panels on one day then? We should have 2 hours with Mr. Baxter and Mr. Purcell. I don't know why we have to be so much in a hurry. They've made a great effort to come here today, and we are just cutting it short, and I'm very frustrated by that. This is an important study. It's an important bill, and thank you for listening to my rave. You can start the time now. Actually, it's not funny. Anyway, thank you, Mr. Chair, and thank you, Josette and Sharon, for being here today. And thank you, Mr. Oliver, for bringing up the bereavement portion of care and palliative care. I think it is incredibly important that there is bereavement support out there and that it is funded. It's key to the families who are survivors of their lost one. I want to bring up another important issue, and that is spiritual care. Spiritual care for patients who are in palliative care or an end of life. I think that it is incredibly important to have that. And I know that cancer advocates and patients and caregivers are raising concern in Alberta right now by a decision that Premier Notley and her NDP government have decided to implement, and that is to remove spiritual care from the funding in palliative care. And I find that to be an extreme shame as well. So I guess my question to both of you is, how important is spiritual care? How important do you think it is in the spectrum of palliative and end-of-life care?
Okay, so we have the national norms and standards for hospice palliative care that were developed in 2002 and revised in 2012, and it comes out with 9 domains of care that are important to deal with when a patient is getting near the end of life. Only one is medical care. So only one refers to the sort of pain and symptom management. The other domains refer to, spiritual care, psychological care, grief and bereavement, and anyways, I won't get into them all because I likely won't remember them all. But there's a lovely little chart in the thing, and they're all equally important. And when somebody's in the last stages of their lives, it's not necessarily just the pain and symptom management, the medical side of things. It is the spiritual care, and it's very important. I hadn't actually heard that about Alberta, but the model of specialist care includes, physician, nurse, social worker, spiritual care advisor, maybe an occupational therapist. I mean, it needs to be whatever is needed, and it needs to be comprehensive.
Palliative care is best offered, like the quality is best when it's a team-based approach, and spiritual care is a part of that approach, and very important. And nurses knew that firsthand, and when we are listening to our patients' conversation at 3 o'clock in the morning when they're in distress. I mean, distress has different meaning, especially when you are living those circumstances of end of life. You are either having symptoms of distress, physical symptoms, or it could be spiritual, it could be symptoms that you need to discuss, and it's part of a quality palliative approach to care.
Absolutely. I completely agree with you, and it's just shocking that Notley is cutting funding in that area. I don't know how much time I have left, but I have to share now, so I will pass on to Dr. Carey.
Thank you very much, Len, and thank you very much, Mr. Chair, and thank you very much to the witnesses today. This is so important, but I want to get right to my question. My first one to the CNA. You mentioned about expanding the training for healthcare providers. What leadership role have you taken in the nursing profession to get that extra certification or specialization? I know some of the other professions out there are working on things, but when you're looking at how to integrate it, the state of training, could you give us some examples of what you think are important?
Currently, where we see gaps, and we're actually working with the Canadian Partnership Against Cancer on nationally examining educational gaps for all professionals, nurses, physicians, and other professional group. And we haven't completed our survey, but we're finding that there are gaps, and we certainly see that this an issue that we should address earlier on in the curriculum and integrate this aspect of care early before the professionals are practicing. Of course, what we've done as an association is provide nurses with experience in hospice palliative care the opportunity to gain a national certification. And it provides them with a specialist title and certification that's nationally recognized. We have 1,400 nurses. They're specialized. It's not enough. We need more. Of course, we're promoting the certification program and attracting employers to really enhance the uptake of this certification. It has a lot of benefits. And continuing education is very important. Right now, before I came to to do the presentation. I was just reviewing the current programs available, and there are very few. There are some in Ontario, certificate, post-certificate programs for nurses, some, one in Quebec, but I saw it was closed, and for the this year, and so very few programs are available, and nurses have to manage continuing education and by their employers. Pallium is a program that's really been successful in reaching out teams and nurses. And also virtual hospice is another great resource for nurses. But we can do more, of course.
So, CHPCA was the co-lead on the FPEC project, which is educating future physicians in end-of-life care, trying to get palliative care education into the curriculum of family physicians. And it ran for 5 years. It was a federally funded program. And even at the end of that, we had about 40 hours of training in the schools of medicine, and that has been decreased over time. So it's not increased, it's actually decreased. We also ran the SCOPE project, which was creating the social work curriculum. I'm actually a social worker by training, and we created a national social work training, but there was no funding to carry it on, and to this day none of the schools of social work actually offer it as a full package. So we've actually done some of the preliminary work of creating these core competencies and curriculum, but we haven't been able to push it out, so it's a growing need.
Mr. Davies.
Thank you, Mr. Chair. I have a number of questions, but before I do, I have to correct the record because Mr. Weber has misled the committee here. There's been no cut by the Notley government of any spiritual specialist. I've just quickly Googled it, and there was a decision to cut a specialist position at the Tom Baker Cancer Center, which was made by the director of that center. And as a matter of fact, it was not a decision of the Notley government whatsoever. And as a matter of fact, I'll quote, Alberta's health minister said the center reassured her office that patients seeking spiritual guidance or comfort at the TBCC will receive it. And her quote, Minister Sarah Hoffman said, is, access to spiritual support can not only be crucial on a personal level to a patient, it can also have a meaningful effect on the patient's recovery and well-being. And added, Alberta Health will be following up with AHS to monitor the situation to ensure that spiritual services are provided. So I just wanted to clarify in case anybody was misled by Mr. Weber's comments. Now, what is true, though, is that the Conservative Party that Mr. Weber is a member of, in 2006, one of the first acts of the Harper government was to eliminate the federally funded National Secretariat on Palliative End-of-Life Care when they first took office in 2006, and that cut a budget of $1 to $1.5 million from that secretariat. Over the last, I guess, 11 years, we've been without that funding. So I think it was you, Ms. Russell, who made reference that it would be your advice that the government should reestablish a national secretariat to coordinate a national palliative care
CNA would support that reinstatement of the secretariat, given all the progress and needs that we currently have in developing a national framework.
Thank you, Ms. Baxter. Pardon me if you've answered this, but I want to be clear. You've pointed out that there are fewer than 85 residential hospices in the whole country with an average capacity of only 9 beds. And you've stated we're talking hundreds of beds, not thousands of beds. And so in your view, approximately how many new hospice beds would we need to make available in Canada in order to adequately address this shortage?
So it's all about providing the right level of care and the right setting of care for the right patient at the right time. And residential hospices are terrific to provide care for those that are dying of like a cancer diagnosis, something that's complex and whatnot. We need more than what they have. However, in a rural community, having one residential hospice in a jurisdiction that has 200 miles of travel doesn't make sense. So we need to look at all the models of care. So residential hospices are important, and we could do a much better and need more. And I won't put a number on how many, but
Has there been any work done on a number? Because that's what my question
There's
is.
not,
is
there's
to
not
get an
a
idea of
firm,
number.
there's not a firm number. And, you know, here's the thing with residential hospices is, in Ontario, the Ontario government has invested money to build more residential hospices, but because their funding model is not 100% funded, they really need the support of the community to be successful, and so they need to be driven by the community.
I want to come back to you about nurse practitioners. The CNA's 2010 submission to the Parliamentary Committee on Palliative and Compassionate Care argued that the federal government should remove federal barriers that prevent nurse practitioners and other health professionals from practicing to their full scope of practice in relation to end-of-life care. Do those federal restrictions still exist? And if so, what advice would you give this committee to improve that situation?
Thank you for that question. Since 2010, we've had progress on federal barriers that was affecting palliative care. It was related to the prescription of controlled drugs and substances, which the regulations were in place in 2013. The remaining federal barriers are in relations to federal policies and forms related to different departments that remain federal barriers to a full scope of practice for nurse practitioners. And we've been meeting with several officials, Member of Parliament, ministers on this issue in the past 8 months, and are progressing well. Everyone understands the issue and is in agreement that these barriers should be removed in order to have an optimal workforce and use of best,
Give that team approach.
That team approach.
Thanks. Ms. Baxter, I'll probably have time for one question. I'll ask you and Ms. Russell if you want to answer this after Ms. Baxter. Ms. Baxter, in a letter published to the Toronto Star last year, you said, "We're at a crossroads. Awareness of hospice palliative care in Canada has never been higher. With the recent media spotlight on assisted dying, we can either focus on making HPC a guaranteed right in the next health accord being negotiated right now, or we can engage in a rebranding exercise. We are largely a death-denying society, and no matter its name, hospice palliative care will continue to be the pry in the room until it is made a healthcare priority." I think those were wise words. In your view, should the federal government propose a standalone funding for palliative care in the current health court negotiations, rather than grouping it in the much broader home care envelope?
So the charge from the Prime Minister in the letter, the health manager said $3 million for home care, including palliative care, including palliative care, and they've stopped the including palliative care in some of their notification, and which is a concern for some of us. You know what? We just need to make it a priority. It can't just be home care that we make a priority, because Canadians die in many settings. But home care is a big issue. If you ask Canadians where they want to die or where they want to live as long as they can, it's going to be home. And we can do a much better job. And if we do fail at keeping them at home, they end up in an acute care hospital bed, which is the most expensive part of our healthcare system. We can do a much better job. The level of patient-centered care in a hospital when somebody's lying there dying is not great. But, you know, in some cases they have to be there because they need more nursing care than what can be provided at home. We need to find the balance. It needs to look at all those settings of care. And it's really important that we do that. I'm not bent on that it has to be under the home care dollars, but it needs to be funded in a comprehensive manner.
Ms. Russell, any opinion?
We think it's a matter of discussions between the province and territory and the federal government, but we were actually vocal around the better home care aspect, and we had an action around advanced care planning in that action plan that I brought a copy. And as Sharon said, it's a matter of having sufficient access in home care, in hospitals when it's needed, and options for Canadians. Right now, they're not having sufficient options.
Okay, thank you. Mr. Chair?
No, you're done. Thanks very much. Dr. Ayalsa, you're up.
All right, thank you, Mr. Chair. Thank you both for coming. I practiced medicine for almost 20 years in emergency departments, and so much of what you say is resonating quite loudly with me. In the emergency department, we see holes in the system from just about every angle coming into our department, and one of them is our palliative care system, or more often lack thereof. people who obviously come into the emergency department, and what they obviously need from the state of their illness is palliative care. One of our frustrations is that very often when the specialist, very often an oncologist, has said, well, there's nothing more we can do, they're put back in the hands of the primary care provider. Primary care providers don't always understand what's involved and how to access that system. Do you see that, you may have alluded to this, but should a national education program of all healthcare providers, and particularly when to bring this subject up, be provided?
So that's what the Way Forward is about. The Way Forward is about palliative approach to care. So it's less about the specialist care and more about the family physicians, the emergency wards and whatnot, being able to have the right conversation with the patient, know where they can refer to if they need to refer, and find the right level of care. We haven't really done that much. This is new for Canada, and we haven't really done that. And I think when you look at the, we did a Ipsos Reid poll of physicians and nurses in this country as part of the Way Forward project 2-3 years ago. And we found great receptivity between these were people not working in hospice palliative care, about knowing more about palliative care and being willing, and citing this as a gap in their care. So the sky's the limit on being able to roll this out, but we haven't rolled it out yet.
Sure, yeah. And further to education, one of the frustrations we also have is there are patients who obviously need palliative care. Their care providers know this, but for many patients and their families, there's a misunderstanding of what palliative care means. And if all they understand about palliative care is that we're giving up. And as Mr. Davies so eloquently said, we are a death-denying society, and we are. And I've had patients come in and they're not plugged into palliative care when they obviously should be, and it's at an hour I can get a hold of their primary care provider, who tells me, I've been talking till I'm blue in the face. They won't accept palliative care because they think it's giving up. This is even more frustrating, or more of an issue in patients from the different cultural group, different diaspora, recent immigrants who are having trouble understanding so much of our society. They think that, oh, they're just all giving up on us and we don't want to give up. So should there also be a push to educate the general public about this, so that people generally have this on their radar before a diagnosis even comes up, before they even think that they need it, that they have some idea of what this is and what it can provide?
You want to go first?
It's very, very true, and we see this firsthand as registered nurses, and it's a whole culture shift, and having conversation and explaining what it means in words that are not so definite, like you're saying, like it's and it's a shift that we've done recently, and we've had I worked in Ottawa as a registered nurse at Briere, and we've had these conversations to the patients and family, and explaining that as their wishes, treatments will continue, and we're here to support them and ensuring that their quality of life will remain. And that's true, that there's a lack of knowledge and understanding of what it means, and as providers, we're not giving up. Yeah.
So there's a national program called Speak Up, Start the Conversation about End-of-Life Care, which is run by my association. It's called part of the Advanced Care Planning in Canada project. And one of the things we found is that nurses and physicians and others that work in the field that don't work specifically in palliative care have a hard time having those conversations. So there's a lot of tools that have been available that are now available to some of the healthcare providers to start having those conversations. And Canadians are being encouraged to have those conversations within their families themselves around what they want and what they think they want and all those sorts of things. It's becoming more and more important to do this as we get to be an aging population, so that we know what our loved ones want. So we encourage that to be picked up too. Again, it's been meagerly funded, so it's how do you roll some of this stuff out? It becomes important that we have these conversations with Canadians.
Yeah, and from my own experience, this is more a comment than a question, is that one of the the shift in terminology, certain earlier medical terminology, and of course in medicine we love our terminology. We sometimes will mean something in a benign way, but it doesn't come across benign to the patients. Everyone remembers when the days that it was common to say DNR for do not resuscitate. That term strikes terror into patients and families. They think if you say DNR, they think someone's being put in a back room and forgotten about. Since we've changed the terminology of levels of care and explain, we're doing the same thing, but explaining, we're doing everything that can be done up to this point, and that one type of care isn't appropriate. We can get people to accept that, which is exactly the same as a DNR, but again, it's just not in those brutal terms. So I think that the medical profession needs to do a better job in getting terminology out there that people understand and are more accepting of, and making sure people understand what these terms mean. I think that could be part of the training, part of the conversation that would help to facilitate a lot of patients into accepting and embracing palliative care.
And the Speak Up campaign has a lot of tools, and we've had great success in providing general education and giving access to these tools that are great.
Sure.
Just so quickly, all the provinces in Canada have instituted some sort of legislative framework around advanced care planning, advanced directives, whatever they're calling them in each province. So it's starting, but it's how do you get to Canadians? It's a big issue.
Exactly. Okay. Thank you.
Okay, that's perfect timing. Time is up, and that completes our round with our president guest. And I think I have to say something because Mr. Weber has raised the issue about not enough time. We just have a 2-hour meeting. We have 2 panels, and we've given 1 hour to each panel. And it's important that we hear from as many witnesses as we can, so you're not being shortchanged. But we just have so much time. We do the best we can. We appreciate your contribution very much. Every presenter today is important to us. Every presenter has something to help us make our decisions. So I want to thank you very much for coming. We're going to take a little break because there's some PowerPoint presentations that have to be set up, and then we'll be right back. going to start our session. Are we underway? Names in the right places. Very good. For our second round, we have the Canadian Society of Palliative Care Physicians with Dr. David Henderson. And Dr. Henderson has given me a primary course in palliative care over the last year and a half or so. And we also have Dr. Martin Chasen, Medical Director of Palliative Care for the Brampton Civic Hospital. So we're going to start with Dr. Henderson, I understand. And all right, you fire away. You have 10 minutes. We're going to have one round of 7 minutes for questions. But you have 10 minutes.
All right. Thank you very much. It's a pleasure to be here. This is such an important issue that we're thrilled to be here to help support this. So to quickly come to the point of the matter, our society certainly recommends the acceptance of Bill C-277, and we've been kind of supporting this concept for quite some time, and we're just thrilled to see this coming and to see the uniformity, across all parties understanding the need and the importance of this issue. So we're happy that this is moving forward, and we're here to help make sure it moves forward, and we'll do what we can to support it. So very quickly, and I know you've already had several presentations and are getting the big gist of things, but just wanted to kind of bring us back to a big picture and down to earth a little bit, that despite Dr. Oz and all the wonderful healthcare you get through Dr. Google, unfortunately still the world mortality rate is still at 100%. So we will all die eventually. So this is really the only issue that is non-partisan, it's non-faith-based, it's not, it's women, it's men, it's children. So this is something that affects everyone, and we're all going to be dealing with this at some point. But dealing with this today is different than it was even 50 years ago. With the advent of some of the advances in healthcare, dying has changed. So we need to, it's become more complicated. We need to be able to address that. So again, I think it's been discussed before about our aging demographics that we're facing, and I think this graph is kind of a nice one to really give that good visual of where we are and the urgency of where we are with needing to move these things forward. So if you look at where we are 2011 to 2021, you can see a very large jump in the people who are going to be 65 and older. We know we're human beings. We know that we've got parts that wear out and break down, and we can't get replacement parts very readily. So things are going to happen, and this is going to be the largest part of the population who ends up driving the demand for palliative care services. And again, as that baby boomer generation is hitting this age group, we can see very dramatic increases in the numbers, and very significantly so. I've actually put myself on there, so I'm coming into this too. So one could say this is a very self-serving thing for myself, because I want to make sure that not only I can get the care that I'm going to need down the road, but I've put one of my children, my son, who's now 15, where he will be 65, so that coming down the road for my children and my children's children, that we have a strong foundation of the type of care that they're going to need as well. Kind of looking around the room, I see a couple of gray hairs here and there, so you know what? If there's no other good reason, folks, this is for all of us sitting in the room, and for some of the younger people sitting off to the side, someday too. So where are some of our current gaps? I've just kind of broken it down very basically into professional, human resources, we've talked about a little bit. So just the sheer numbers of people with a little bit more of that advanced training in palliative medicine, or the specialty training. So that kind of builds into the skilled providers. And along with that aging demographic, it includes those of us working in palliative care. So we've got an aging demographic of skilled labor as well that needs to be replaced as time goes on too. The current gaps from the public issues, access has been kind of well documented now that's a big issue. There's pockets of places where access is pretty good, but likely could be better. I know in our neck of the woods, because in the East Coast we do have some of that aging population, we're probably a little bit skewed on the curve. We have wait lists now to access palliative care services, which is, just atrocious. But that's the reality of the world right now. As I said earlier, people are living longer with multiple comorbidities because we've been able to kind of manage their renal failure, manage their heart failure. They've got a couple new arteries in their heart, so they're pumping longer. We've advanced some things, but at the end of the day, we still now have people with more chronic comorbidities that complicate things as they're getting older and as these organs and parts still continue to wear out. So it is higher complexity from the physical nature of it, but it's also higher complexity because of our generation too. We've got a lot of people who have been moving back and forth across the country for work opportunities in the way of our children, so there's often not as many caregivers around family-wise to be able to help provide that care in the homes that we used to have years ago. And again, with the aging demographic, we've got the higher numbers requiring care, and because people are living longer, often there's lower numbers of care providers. If someone is 91 and their spouse is 92, and there's a fair bit of physical care that needs to happen, there's just limitations because of that age range as well too, of what they can and cannot provide physically. Informational gaps that we're facing. Again, we still don't have national indicators for palliative care across the country. We don't have our national standards. There's no national reporting, and there's no national oversight. And that's one of the key things I think this bill can actually bring to the table, and really needs to bring to the table, that large-scale look at how things are going in a unified way, so we can start to look at how are things being done across the country and optimize best practices and make sure they get translated across the country so that we can all do better. There are some great projects and great work that's been done. Now's the time to be taking those and implementing those across the country. I've said in the past, the time of pilot projects should be done. We need to be moving forward. Just very briefly, one statement, and I think Mr. Oliver maybe made a comment on this earlier. Medical assistance dying is not a choice when there's no other choice. And unfortunately, that's the way it is in Canada right now because of the lack of access to palliative care services. Bill C-277 would fulfill some of the recommendations that were brought forward in the Special Joint Committee on Physician-Assisted Dying. Specifically, number 19 called for the reestablishment of the Secretariat on Palliative End-of-Life Care, and Health Canada work with the provinces, territories, and civil society to develop a flexible, integrated model of palliative care by implementing a pan-Canadian palliative care end-of-life strategy. Number 18 was ensure that culturally and spiritually appropriate end-of-life care services, including palliative care, are available to Indigenous people. This bill would also ensure that palliative care providers is provided to the people that the federal government are responsible for providing health care to. The groups under federal jurisdiction include First Nations people living on reserves, the Inuit, serving members of the Canadian Forces, eligible veterans, inmates in federal penitentiaries, and some groups of refugee claimants. So there's that population that this needs to help ensure that we've got the national standards for as well. Within the bill, it talks a little bit about the Canada Health Act. And really, when we start to look truly at the Canada Health Act, there's a comment in there that states that all Canadians should have universal comprehensive access to care. Approval of Bill C-277 would ensure that Canada sets the standards for access to quality palliative care for all ages, including children, all geographies, and all diagnoses. To ensure that Canadians have access to high-quality palliative care, we've developed a couple of documents recently that we have sent forth to all the members previously, and certainly can make available again. The web connection is present there for you. Basically, it's stating clearly that we need to look at implementing a palliative approach to care, as outlined in the National Framework Document, The Way Forward, which you've heard about today and I think previously as well. That document is a good foundation for how things should be moving forward, and we have endorsed that as well as many other palliative care organizations and other organizations throughout the country. So again, we don't need to start from scratch, and one of our key messages is we need to start to work on implementation as opposed to truly full, further development. And the second document that we just released a couple of weeks ago was looking at the cost effectiveness of palliative care. And just very briefly, a couple of comments there. Through some of the different studies, it looked at lowering costs delivered by up to 30%. But even more importantly, when you look at the delivery of this care, it will also help to free up scarce resources in acute care, such as beds in intensive care units for patients that truly need them. So when palliative care can be involved early on, you start to have some of those discussions about goals of care and what the patient's wishes are and their understanding of their illness, and they can realize that yes, going into the ICU may not be what's really in their best interest. It's not going to fix things, and if we can keep people out of the ICU that there really isn't going to be true benefit for, it opens up those beds for somebody else who truly can benefit from being using up those very limited resources. And again, we come back to that aging population. There's going to be bigger demand on everything throughout healthcare. So there's going to be more people that do need those intensive care beds. So we need to be really making sure we utilize our resources as efficiently as possible. And at the same time, while we're offering the same type of care, we're improving the quality of life and quality of care for patients with serious illnesses and their families. Healthcare costs have been escalating as a consequence of our failure to adapt to the changing demographics of Canadians and advances in chronic disease management, including cancer. Change is now long overdue. Continued failure to invest in palliative care will be a lost opportunity to achieve better efficiencies, improve outcomes, and reallocate budget to other priorities. The status quo really neither meets the Canadians' needs or financially is sustainable. So what we're recommending certainly is the forward movement and acceptance of Bill C-277. We'd really like to see an established, well-funded secretariat and the formation of a small, nimble, high-level working group made up of key national organizations to work with the secretariat to start working on implementation. Focus needs to be on administrative cost containment so that funds can see their way to the delivery of services. We've seen other projects go on and lots of money put into major infrastructure, which unfortunately hasn't translated into a lot of key things hitting, rubber hitting the road. This is something that there's lots of good work happening across the country. We have shown in the palliative care world, we work well together. We've been doing things on a shoestring for years. This can be done efficiently, and we want to see the monies get to providers out in the areas with increased resources so we can actually make those differences that need to happen. We need to bring in additional stakeholders when and where required to develop the efficiencies, gain the insights, and mobilize strategies. Having another 100-body committee to work on things is going to be very slow, tedious, and again, you see by that demographic curve, we're into it now. We don't have 10, 15 years to be doing this. Our hospitals are already starting to be overloaded. I know in Nova Scotia we have overcrowding. They're having to develop new terms to label the levels of overcrowding that we're having in some of our hospitals because of this aging demographic and the demands. So what is needed? Again, we start with what we know. Again, we really need to be collecting standardized national data. That can happen as well through a national secretariat to help move that forward and make sure that we're doing this. Setting, monitoring, enforcing national standards, indicators for palliative care in Canada, make accreditation of healthcare services, both in hospitals, long-term care homes, home care services, etc., all mandatory and contingent on palliative care services being provisioned to nationally accepted standards. We also need to, and my colleague here will be speaking to this, I think, a bit more, standardize and insist on integration of core competencies in the School of Healthcare Professionals. We had the opportunity to hear from the Canadian Nurses Association today, and I know for medicine, for nursing, for social work, for pharmacy in particular, the core competencies are developed. The big challenge has been getting those integrated within the healthcare professional schools. So that is something that we may need some federal pressure to help make that happen. We've been advocating, we've been trying to get that to happen, but there's so much competition for that time within our professional schools that you have to look to take something out to add some more time in. But at the end of the day, what we're doing is so fundamental, it needs to be there.
Okay.
There you go.
Thank you very much. Okay. Our next presenter is Dr. Martin Chason. So you have a slideshow as well. There's a sailboat. Perfect. Our favorite sailboat.
Okay. So good afternoon to all of you. So I'm a clinician in the trenches, and I think a lot of what I'm going to say to you is going to answer a lot of those questions, because I'm going to show to you that it's all practically possible and it delivers good results. I'll present myself as from South Africa. I came here in 2004 to McGill initially, then went to Ottawa, and I'm now in Brampton. I am a qualified internal medicine specialist as well as a medical oncologist, and I also have a degree in palliative medicine. In South Africa, which has the reputation of having the most hospices in Africa, we indeed have a recognized university degree. I was of that first class that got it in 2004. So we do see that it changed a lot of government policy by having it formally recognized. I'm going to reference two documents. The first document is the Bill C-277, which clearly says that in order for a patient to have a proper and to really have a voluntary decision to participate in medical assisted aid in dying, he must be given the choice for palliative care. I think that has motivated me a lot to develop what we've done. And then I'm not sure if any of you know this, the 2015 Quality of Death Index. It's a report by the Economist Intelligence Unit, and I think this is enough motivation to say that Canada is at number 11 on the list. This is not good enough. Before I got to Canada, I did read that the Honourable Irwin Cotler in 2002, when he was Justice Minister, said that palliative care is a basic human right. And I think we should move forward on that one. So you may have heard that many definitions of palliative care being an approach that looks at patients and their families who have life-limiting disease. It's impeccable symptom management. It definitely involves psychosocial, it's spiritual, physical, and every other domain of a human being. It's holistic care. At the World Health definition, there is a little attachment which people don't know, and I'm going to specifically speak about three of these attachments. Firstly, that palliative care affirms life and regards dying as a normal process. It doesn't hasten, nor does it postpone death. It offers the full support system to help patients live as long as possible and as actively as possible, keeping people as comfortable as possible for as long as possible. It has a goal of enhancing quality of life, and once again, applicable in the early course of illness. This is not just about end-of-life care. We now know from many clinical trials in patients, the most topical one is in patients with metastatic lung cancer, those patients who were randomly assigned to receive palliative care and normal chemotherapy had less chemotherapy and lived longer. So, this is the model that we've put together initially in Ottawa and now in Brampton, and really what it looks at is the 4 pillars. This is a model where we start off with an inpatient palliative care service for those patients requiring specific specialist palliative care. Terrible pain that's not controlled, extreme anxiety, existential issues that the patient needs to come into hospital to be treated in a palliative care unit. We as well have a consultative service in our hospital where patients are referred to us from the different wards, orthopedic, medical ward, geriatrics, internal medicine, and I'll show you that. So patients are seen and are treated in conjunction with their most responsible physician. We cannot see all the patients. There are more than enough patients. So our aim is to build capacity. And I'm surprised that nobody's speaking about building capacity at such a great level, but we have an enormous obligation to build capacity. Then what we've recently started is the ambulatory outpatient clinic, where patients that are seen and that are able to come to the clinic are seen. And then, and I'm going to show you some results of this, we have a robust community service. We have patients as being seen in their home by a physician as well as a nurse. We work as a dyad. Around this center, this pillar, these 4 pillars, we are embedded within education, because without education, we will never be able to build capacity. So in our specific area, in the LHIN, we have made it a goal for us to have as many of the LEAP courses, the Learning Early Palliative Care. I'm sure you've heard of that with the Pallium project. So we are trying to do as many as we can to build capacity. And then, of course, we all need to know that research is important. Why is it important? Because research allows you to have that margin of error. It tells you you are not doing as well as what you want to do, that you need to research this in order to get better. It's a self-audit. So this is our model, and it works. I'm just going to briefly show you, since I started this program in Brampton, these are the patients that have been referred to us as new patients. And you will notice that the majority, more than 765 patients, have actually been referred to us from general internal medicine. Palliative care is not only about patients with cancer, and I will once again ask you to please not call them palliative care patients. They are patients with cancer, they are patients with cardiac failure, with renal failure, with chronic obstructive airways disease, they are patients with a terminal disease. So we are getting patients from all spheres. Understanding, of course, and this brings in, how do we bring it in earlier? How do we start the earlier goals of care discussion? Even having a look at from the ER, where we've had 104 patients referred directly to us, starting the earlier care, advanced care directives. Not necessarily saying that a DNR doesn't mean any treatment. I kind of like the term ANC, allowing natural causes. But of course, explaining to a patient that means that everything possible that can be done will be done in order to keep them as comfortable as possible for as long as possible. So here are some little graphs which we can show you since we started the palliative care outpatient clinic at the Brampton Civic Hospital as well as the Etobicoke General Hospital. We only got it going in April of last year, but already you can see that we are having more and more patients referred to us. This is on an outpatient basis. We have already admitted 60 patients directly from the community through the outpatient clinic into the ward. They have not gone to wait for a day or two in the ER, where you have 400 to 600 visits a day, where you have people coming from the long-term care facilities that can wait 30 hours there, where you have 300 patients from the long-term care facilities that actually died in the ER while waiting to see a doctor. So seeing them in the community, putting them into the outpatient, and then, if necessary, admitting the patients. Now, you will notice, of course, that the last month or two, we've had a decrease in palliative care clinic visits, and the reason being is we've had more home visits. We're taking the palliative care to the patients where they want it, and wherever we can do it as is best. But it's a dyad. This is teamwork. This is about communication. This is not about the patient belongs to me. And that is where I appeal to you to try and get a funding model that is not fee-for-service. If you have a funding model that's not fee-for-service, everybody can be obliged to do education. Everybody can be obliged to do research. But when you've got a fee-for-service model, it's about how many patients I can collect. So that is the one recommendation that I would say. We move the patients into the community, but of course we change the funding structure of how people are paid. The other program I'd like to speak to you about is the palliative rehabilitation program. So this was a program that was designed and implemented very successfully here in Ottawa at the Elizabeth Bruere and the Ottawa Hospital. The goal of palliative rehabilitation is there to enhance the physical, psychological, social, and professional well-being of the patient, answering the questions that were asked by Mr. Weber about, do we look at the spiritual aspect? Each one of our patients gets a spiritual history. You can have a physical history, how's your pain, how's your nausea, your vomiting, your anxiety and your depression, but your spiritual history. Do you have faith? How important is it to you? Do you have community that you work in? Do you have community support? And how would you like me as your physician or your healthcare provider to provide a spiritual backup for you? So the palliative rehabilitation patients were seen here. And I'm just going to show you, this was an 8-week program that we had the patient see the OT, the physio, the dietitian, the social worker, the nurse, and the doctor, with the patient and the family at the center of the team. These are values that are taken before the program and 8 weeks later, and you can clearly see the statistical significance of the general activity of the patients that's improved, their mood, their working, their relationships with others, their walking, as well as their enjoyment of life. Validated tests shown statistically significantly. And I have to bring you one of these because this is a patient testimony. And if we're talking about patient-reported outcomes and what it means to the patient and the family, I feel I have been remiss in not writing to you sooner. I cannot say enough about how positive I felt being involved with your team. The thing that impressed me most was your profound respect for me. I think that this was only surpassed by the admiration and respect you had for each other. This allowed me to open up and be more trusting. I knew that anything I shared of value and significance was relayed to other team members, and my wife and I were no longer on our own. None of our patients want to feel helpless, hopeless, and abandoned. That's our job, to take that away from a patient. Simple things seem to take on a profound meaning. You need to eat more, or don't feel guilty about resting. You don't have to endure the pain. That's why we give you medication. Are a few things that come to mind, and as I write, I realize that the most important thing is that we felt we were part of a team, and that made all the difference. And so how do I see the future? I see the future with public health, billboards at the side of the road saying, this is palliative care. It is not a physician-assisted suicide. I also say to you, palliative medicine specialty training needs to be brought to the fore. It's happening. It needs a push. The funding of hospital and community palliative care rehabilitation teams, which is not an expensive funding model, and then, of course, to push the LEAP as well as the Pallium educational sessions and research. I thank you for your attention.
Thank you very much. Now we'll start one round of 7 minutes with Ms. Sidhu.
Thank you, Chair. Thank you, Dr. Henderson and Dr. Martin Chazen, coming from Brampton, Dr. Chazen and Dr. Henderson, and your valuable presentation. It is a very impressive and eye-opening presentation. And first questions, Dr. Henderson. Does your organization have a recommendation about how we reduce the regional disparities and gaps for palliative care between urban, rural, and on-reserve regions?
We're actually working right now on some staffing models, and as my colleague here says, part of the problem with trying to develop what human resources are required for palliative care is there aren't any good evidence-based models of how many numbers of people that you have. What is out there starts to talk about, well, here's how many physicians you need, and that's all it looks at. This can't be looked at as a physician resource issue without looking at a whole team approach. And that's the model that we're looking at. You also can't look at it from a purely demographic numbers approach either, which is often how it's done. You need X number of doctors per 100,000 people. Well, 100,000 people in an older part of the country versus, say, Calgary, where you generally have a younger population, that same 100,000 people, when you look at those curves, how many people are over the age of 65? Where are the demands at this time? So we're developing a model that really will be looking at the team approach, how many nurses, how many social workers, pharmacists with extra training in palliative medicine, and palliative care physicians as the specialty team need to be in an area based on really even going back and looking at our death rate, because that tells you how many people, as a better number than just pure population, are needing these kind of services. So we're in the process of working on that right now, but that is something that's very much needed. There's great models across the country showing how this can be done. And again, going right back to Dame Cicely Saunders, who was the founder of the modern hospice movement, she said, this is best delivered by an interdisciplinary team. So having access to that good quality palliative care nurse, I honestly see the palliative care nurse as the key ingredient to this whole mixture, especially for community, rural, urban, everywhere, because you can have more nurses out there working with the primary care teams, physicians, nurse practitioners, and so on, helping to guide them a little bit, but helping to ensure the right assessments are being done, the right information is getting to the primary care team, and when it's more complex, then being able to pull in the palliative care consultant to be able to help with that more of that expertise. So I think that's the way we need to be looking and moving forward. So we are working on that, and hopefully over the next few months we'll have some better, more clear. I know what we need. What I can't tell you yet.
Thank you. Dr. Chazen, I had opportunity to go to the Brampton Civic Hospital where you work and also toured the geriatric ward. And can you share some of the challenges faced by palliative care unit on the front line at Brampton Civic, which would provide a useful tool to making C277 and a future national palliative care plan?
Okay, so the international formula, and I know this question was asked, how many hospice beds do you need per population? So the Gomez formula dictates between 8 and 10 hospice beds per 100,000 population. So if we have 1 million people in Brampton, we are looking at a lot more than 10 beds, which is what we have at the moment. There are initiatives at a provincial level to build hospices, but we have the issue of that 54% of patients are dying in acute care hospitals when we don't really want 54% to be dying in acute care hospitals. We have shown that the better the community supports, the more likely the patient is to go home and not bounce back into the emergency room. So I think that's where our issue is. We don't need necessarily only hospices. We probably need some form of a step-down facility where you don't have a physician going in every day, maybe every second or third day, where you don't need one nurse per 3 patients, but maybe one nurse per 5 patients, where you concentrate more on patient care, not just necessarily giving them the medication, where you bring in psychosocial support, which is so poorly lacking. There's very little funding for spiritual support, for psychosocial support. A lot of that funding is being brought in privately, or for people are donating money, and we're raising money from a charitable organisation. I think palliative care needs to be brought into the Health Care Act. Hospices really need to be brought in as well, that they're not a separate entity, and that could increase the continuum. We don't need fragmented money coming from different areas. We need one pool, and everybody should be going on along that line.
And as you know, the William Ostroll Health System recently opened the Peel Memorial Urgent Care Center in the Peel Memorial Center for Integrated Health and Wellness. As we look the way the best provide palliative care, can you speak about those facilities as alternative method for our healthcare delivery, and also can you elaborate for the home care visit how this model works?
Okay, so I'll start off with the home care visit. We work with nurses, the CCACs, which are now part of the LINS, because it's all at a provincial level. We are making a concerted effort to train as many nurses in that model as possible, going through the LEAP courses and the Pallium courses, which of course raises the standard that we should be measuring. We should have outcome measures of how many nurses qualified through LEAP this past year, how many volunteers, how many physicians have managed to do the LEAP courses. So the nurse-doctor model is the most ideal model. I do think there is a role for nurse practitioners, specifically in areas where there is no physician. I do not think that nurse practitioners need to do this on their own, to take that responsibility, to actually behave like physicians. The job of a nurse and the job of a physician are not the same. So definitely the dyad is the best. In areas where you don't have a physician, then perhaps the nurse practitioner can take on the most responsible person for the patient. The Peel Memorial site is, of course, to get more patients to be able to get more care. There is one of the areas which we as the palliative care physicians will be involved in, and that's a nurse-led clinic looking at patients with chronic medical problems. And one of our goals over there is, if we think that ask the surprise question, which is a gold standard framework question, which is not ours, it's developed in the UK, which, by the way, are the highest country on the quality of death index, where the surprise question is asked when the patient comes into the emergency room. Would you be surprised if this patient would be alive within 1 year? If you would be surprised that the patient would be alive, he needs to have a goals of care discussion. If you're not able to do that, find somebody that can do that. Because perhaps what you think is good for the patient or the family don't really always think is good for the patient. So that's what I would suggest.
Time's up. Mr. Weber.
And thank you, Dr. Chazen and Henderson, for being here today. A question to Dr. Henderson, and I'm going to come back to spiritual care again, and how important do you think it is in the spectrum of palliative and end-of-life care? How important is spiritual care to you?
It's imperative that it's part of it. I've said throughout my whole career that the pain and symptom management part of it is the easy stuff. It's the existential suffering that is always the hardest. There's so many things we can do for all the other symptoms, but at the end of the day, this is a monumental time in people's lives, for the person, for their family, and we pull apart religion and spirituality. More and more in our country, people have moved away from organized religion, but inevitably everybody has some sense of spirituality, and it's imperative that that's brought into the picture. Otherwise, you miss the boat completely. Even when we teach about managing pain, we talk about something called total pain, and that's part of it. If you're not addressing that component, you sometimes can't get their physical pain under control because we're missing that piece of the puzzle. When you're saying about Alberta cutting it, and I understand that wasn't quite accurate, but my first comment to Catherine Downer from Pallium sitting beside me was, there's some place in this country that gets funding for spiritual care, because it's not in most places. We rely on really the generosity of spiritual care providers that we identify to work with our teams, who see this as a real need. And honestly, it's a challenge to find, like across the spectrum, we talk about education, needing to have our nurses well-educated, physicians, so on, from the spiritual care community. They need to have education in palliative care. I've been in some situations where a spiritual care provider has come in and completely traumatized the situation, deciding that everybody needs to pray for a miracle when the rest of the family were at peace with, dad is dying, small children in the home, and somebody comes in and says, well, we need to pray for a miracle that this doesn't happen now. That wasn't helpful at all, and we had the wife come crying out saying, please pull him out of here. So it's important that you find the right provider that can do this kind of work in no matter what area, including spiritual care that we go through, but imperative that it's there.
Absolutely. And I would think that Dr. Chiasson, you've nodded your head a few times in these comments. You would agree
Absolutely.
as well.
As I say, all our physicians now do a spiritual history. It's not developed by us. There's a lot of scientific literature being written by Christina Polchilsky specifically. It's a quick part of the history, but it's a definite part of the history. You cannot look at the total person without understanding what their frame of reference is. What is their moral standard? Where do they come from? What do they expect? What do they want? It's a mind-body game we're in.
Mm-hmm. Yeah, thank you. And Dr. Henderson, you alluded to Mr. Davies' research on Google, indicating that I was misleading this panel here. I did some Googling as well, since being accused of misleading this panel, and I can quote a Google article from Red Deer, Alberta, indicating that Alberta Health Services is changing the way it delivers spiritual care at hospitals in the central zone of Alberta. The contracts of about 11 part-time hospital chaplains are not being renewed. These are decisions made by Alberta Health Services, who is being funded by the government of Alberta. Premier Notley and the NDP government could end that tomorrow. They could provide funding, bring it back, but they chose not to. So to be accused of misleading this committee is false, and I would suggest that perhaps Mr. Davies do some more Googling and read some more articles, and perhaps maybe come to the hospitals. I've talked to patients who are devastated over the fact that these cuts are being made in spiritual care, and it is disturbing. So I suggest some more research there, Mr. Davies. I would like to ask Dr. Chiasson from South Africa. You indicated that we ranked number 11 in the world with regard to his palliative care quality.
Quality of death index. It looks at various aspects. It looks at the palliative healthcare environment, the human resources, affordability of care, quality of care, and community engagement. Those are the 5 indices. I think there's something like 80 different specific topics, but this is an international document and one that we can be judged against.
Absolutely. from South Africa. Where do they rank in this, and your experience there? Is it something that we can learn from other countries? What they do, obviously it is, because we are ranking number 11.
I think South Africa fall down on a lot on the amount of money that's spent specifically for palliative care, but they bringing it into the governmental policy. There's a clear vision. There's accountability for that vision. There's continued auditing of that vision, and there's setting of standards, and that's what we need to do here.
Absolutely.
And they struggle because we take their best doctors.
Yes, exactly. Now, you indicated, Dr. Henderson, too, that there's some great work being done here in Canada. And any specific places where we can learn from their best practices that stand out from others in Canada here? Could you share that with us?
Almost across the country, you can find a pocket of something like, wow, that's great. I mean, I'm from the East Coast, so I'll just bring this one up because it's quite new, is we did a project in partnership with Prince Edward Island where we did training with our paramedics. You may have heard of that. So very quickly, they were looking at, it started off with paramedics actually extending and doing a little bit more work in long-term care facilities where they had their advanced paramedics able to go to a long-term care facility and do a little bit more of an assessment, call back to a physician, and ideally keep that person in a long-term care facility. Discussions started going on and saying, well, can we do this for other special patient populations? And we talked about palliative care. And so we said, yeah, that sounds like a great idea. As you start to look at that 24-hour coverage, how do you get access in the middle of the night, weekends, and so on? They said, yeah, this is a great project, and we got some funding through Canadian Foundation for Innovative Health. And they started saying, okay, we need to do education. So I introduced that project to Pallium, who within a couple of months developed a LEAP Pallium, or LEAP paramedic rather, which formed the standard training. And again, over about a month, we provided training to every EHS professional in Nova Scotia and Prince Edward Island, got the project up and running. So now there's a special patient population that we, as our palliative care teams or even a primary care physician, can register the patient for. It provides more information to EHS so they'll know what potentially they're responding to. Within that, there are more goals of care for the person, so they know that, yeah, you're going to respond here, but this person does not want to go to hospital. So they know when they're going to respond that they may need to help address some acute shortness of breath or acute nausea, vomiting, something like that, as opposed to I need to go pick up this person and take them to hospital. And it's gone over tremendously. And actually, I still have on my to-do list, I have to write a note back. Yesterday, I had a case of one of our patients who developed nausea, vomiting through the night, quite dehydrated, quite elderly, and was looking at probably heading towards the emergency department. Our EHS colleagues arrived, and the comment from the daughter was, I so much appreciated that they stopped and said, okay, let's look at what's going on here, as opposed to, okay, she's got this symptom, let's get her to emerge. They said, what else can we do here? And what are her goals? And they said, ideally, she does not want to go to hospital. So they were calm, they discussed it, they gave me a call, we did some interventions, they gave her some fluid at home, gave her some anti-nausea medication, and I was able to drop in a little bit later on, and she was doing much better. So there was a patient who avoided an emergency room visit. She was happier, her husband was happier, her daughter was happier. They complimented the EHS team. So my to-do list is I need to send an email back through our folks to give a pat on the back for those EHS providers, because it's always nice to hear that your work is appreciated. So that's one project, but there are many right across the country. Alberta is actually doing the same project, and now the LEAP Pallium, or sorry, the LEAP paramedic has incorporated some of the Alberta things too, so it's adapted a little bit. But there's now really 3 provinces this is had uptake in, and it's starting to spread across the country. So there's lots of great examples of that, of using people that, 10 years ago, we wouldn't have thought of EHS as being a partner to play in this. But again, in that 2 o'clock in the morning, they can go, they've had some extra education. In Nova Scotia, they actually have some different tools and medications on their buses now that they didn't have previously. So now they're able to help make more things happen. So.
Okay, Mr. Davies.
Thank you. So, Dr. Henderson, I take it the prime lesson we have to take from this is that none of us are getting out of this alive. Is that right?
Absolutely.
Okay. First of all, I want to thank both of you for taking the time to be here and learned a lot from both of you. A number of questions. I think it was maybe you, Dr. Chasen, who talked about the wait list. Can you give us an idea of generally how long the wait list is, or was it you, Dr. Henderson? I'm sorry. To access palliative care in Canada?
Oh, in Canada, no, I can't tell you that. A lot of places kind of choose not to have a wait list, so they'll keep trying to see people just as quickly as they can, which means the caseload for their staff end up becoming kind of monumental. So even within Nova Scotia, there's caseloads where, kind of based on the nurse's caseload, they could have 80 to 90 to 100 patients on their caseload. Well, you can't see most of those people. So how many of them need to be on the caseload? You know, they're just not getting the attention that they need to be able to keep them from needing those extra emergency room visits and so on. In our district, we've chosen to keep a reasonable caseload per nurse of about 25, so that they are able to make the contacts, and that 25 is kind of constantly changing.
So you made a reference to wait list, so I'm just trying to find out, it was your term.
So we've been up
to?
close to 2 months wait list.
2 months?
When the average life expectancy is about 6, right? So for somebody...
And I've seen some references to the number of people who would like to access palliative care but end up not. Do we have a general idea of how many people are actually getting quality palliative care and how many are not?
The oft quoted figure in the Auditor General's report is about 35%.
Are receiving palliative care. Thanks.
Have access to it, yeah. Does the Cancer Care Ontario have a provincial standard in the cancer centres of having palliative care patients seen within 2 weeks? But that's in a cancer centre, in a specialised centre, which I do believe is not where the majority of patients are going to be seen. So, you know, in order for us to do what we've done and seen those patients in the community, we've had to employ doctors. I will say that palliative care is actually very cost effective, because those doctors don't cost the hospital any money at all, other than maybe a computer, and hopefully they can get a place to hang their coat on. But you know, those doctors are not ordering blood tests, they're not ordering x-rays, they're admitting patients and trying to get the patients back into the community. We can't really see where that saving comes, but we do know, for instance, that 60 patients didn't go to the ER and wait there, that went straight into hospital. So it's very difficult to understand how to measure the savings when all of it goes into the black hole of the exchequer.
Right. Now, Dr. Chasen, in terms of, I think last meeting we had some testimony around the need to maybe increase education in medical school for physicians on palliative care. Now, I'm getting a sense from you that it's a whole specialized field and specialty in and of itself. But what can you tell us about what you'd like to see in Canadian medical schools in terms of the amount of time and training they give to each graduate of medical school on palliative care, or Dr. Henderson, if you prefer?
No, I'm going to ask you to speak.
Sure. Actually, we've just kind of gotten the green light to go ahead and do a refresh of, I think Sharon Baxter mentioned today, the FPEC, the Educating Future Physicians. So the core competencies were developed, again, it was 2004 or 5, and the problem was getting those core competencies integrated within the medical schools. And what we've seen through some recent research is the number of hours of this baseline undergraduate education has actually diminished in most schools to where it's really quite low. So the core competencies are developed. We need to get them implemented within the schools. We are going to look at refreshing them, but there won't need to be that much changes in them. So that's there for physicians. Core competencies are developed for nursing. And again, they're having a harder time because there's that many more nursing schools getting this education into their core curriculum. Again, it's a challenge. You know, they've only got so much time. So if you're trying to get something else in, it means you got to take something else out. Yeah. So, you know, and everybody's got their own baby that they want to, you know, hug and keep in there. So it's a huge challenge. The reality is this education crosses so much. You know, you don't even have to call it palliative care education because it's applicable to everything you do in healthcare, because so much of it's about communication, effective communication, listening to the patient, understanding their goals of care, whether they're coming in for gallbladder surgery. You know, if you can do pain management better, you know, and nausea management better, you're going to do well.
How much time do we have? 2 minutes, thanks. I want to end with two questions and let you just tell us your opinion. One is, Dr. Henderson, in an editorial you co-authored in the Globe last May, you said the lack of end-of-life care in Canada is a national failure to address dying with dignity from an ethical, funding, and continuum of care perspective. This failure must be acknowledged and corrected in the current discussions around a new health accord between Ottawa, the provinces and territories, and Indigenous peoples. So what would you like to see in the new health accord to correct that failure? And I'll ask either of you. And basically, the last question I'll have is, what is the most basic, fundamental, most profoundly important advice you would give us as federal representatives to help address this important issue?
Okay. So again, we need the leadership and the somebody, you know, holding the rudder of this ship. So the bill C-277, having a secretariat, starting to form work group who can have that oversight to start to put the standards, make sure they're in place, the indicators and so on, so we can gather the proper data so we can see where the real gaps are, and then really start to fill those. We've got lots of recommendations on how the gaps can be filled, but we need that oversight and the authority to start saying, okay, this has to happen. And there has to be an investment of some monies. And I know there's been promises of monies going towards home care. I was around actually in Nova Scotia when the last health accord came around, and there was the basket of services. And within that, there was supposed to be a fair bit of money for some palliative care issues within the provinces. I know in Atlantic Canada, it was years before we saw anything happen. We did eventually in Nova Scotia start to see some improvements in the amount of home care patients with palliative care needs could have. It was just 2 years ago that we actually got medications, what we call a palliative care medication entitlement in place. So it was that long after to get anything happening. And so those are very basic things. We've seen we haven't had any increase in staffing for our program since 2004, despite having like a 400% increase in referrals. So we need human resources. We need the specialty teams who can then start to work out, fan out, provide the education, the mentorship, the capacity building to kind of raise the tide so all the ships rise and we can all do this better. Sure.
Time's up there.
I do speak after David, who's president of our association, but it really needs to come onto the front burner. You know, that's what we need. Palliative care is not an add-on. It's part and parcel of what medicine is. It needs to be brought right into the front burner with the vision, with the implementation, with the auditing, and with, you know, and with the improvement, continual improvement.
Okay, Mr. Ayoub.
Merci.
Thank you, gentlemen. It's always concerning and very informative.
It's going to be much easier for you guys. How long do I have? How many minutes?
7 minutes.
7 minutes? I think it was your round.
I think it's my round.
It's your round, because
Well,
I was on the 5
you
minutes.
can. Do you want to?
I don't mind. If you've got more, you want to go? Go ahead.
Well, I just wanted to be clear because there's been a lot of, first of all, thank you very much for your presentations. Excellent content. But just to be clear about the committee, we're reviewing the bill. So much of your comments were very, very important and very, I think, insightful. They're probably for the next phase. If the bill gets approved, then the minister would convene provinces and territories and palliative care providers such as yourselves to talk about how to build the framework and then how to move that framework forward across Canada. So a lot of your comments and some of the questioning from the committee is really, I think, in the broader second stage context. So our job is to review the bill and modify it or approve it. So I guess that's my first question to you. You've both seen the bill. Did you feel there was any amendments, any changes that you thought would be appropriate to it?
Yes, and we've submitted our document. So we have really one change.
But that was about data gathering, wasn't it?
The one change was take out develop and move straight to implementation because so much has been. Sorry,
what was your amendment again?
Our submission to this committee.
Yes.
The only recommended amendment would be delete the words develop and from 2-1 and just implement a framework designed.
Okay, so the issue, just so you're aware, with that amendment, there's federal and then there's provincial and territorial. Right. So an implementation of a palliative care program is absolutely federal, territorial responsibility. So the role federally would be to work to make sure there's a framework put in place, to have definitions around it, but implementation is operationalizing is federal, provincial, territory. So just to provide that feedback. One area in the framework, in the preamble rather, of the bill, it doesn't talk broadly about the benefits of palliative care and why we need it. And much of your presentations were around, the significant shortfalls we have. It's more couched against that since we now have physician-assisted dying, we need to have a full palliative care program around it. Personally, I would have liked to have seen a broader endorsement of palliative care, not because we have PAD or MAID, but because we need this regardless. Did you read through the preamble? Did you have any thoughts on that?
So I fully agree with you. I mean, it seems as if this is in reaction to the medical aid in dying, when it actually should have been the primary care that should have been given to the patients. Whereas palliative care, as Honourable Irwin Kotler said, is a basic human right. That should have been the model that should have been presented, and then later. However, it didn't happen that way. So we now move forward and we say, yes, we need to present palliative care as a viable option, but understanding, of course, what palliative care is. And that's why I think public health is very important in this, is to make the populace aware of what palliative care is, that it doesn't mean it's just a one-way ticket.
In going back, through the years, the former Secretariat, Sharon Carstairs, who served, there's been so much work done much prior to MAID that was outlining the need of palliative care. And the reality is those of us working in palliative care knew for years that the only thing that was going to put palliative care on the minds and eyes and tongues of Canadians was when euthanasia became an issue. And that's really the only thing that has brought it to the public's attention to push this forward, which is why I think we are kind of tailing on to it, because we don't want to see palliative care fall off again, which is a big concern that we have had, that as soon as the MAID propaganda kind of dies off, no pun intended, that palliative care will be shoved back in the box and back in the corner and won't be looked at again.
Okay, that's excellent. That's an excellent perspective on that. Thank you. And then under D, the wording in the bill is collects research and data on palliative care. This is the role. This is the framework. And you had some wording change that, did you not? Did you not say collect standards, or was that the people before you? Did you have wording change on that?
Well, I mean, we need to have the standards clearly defined. So even with Accreditation Canada right now, they're looking at there's accreditation standards for looking at palliative care within facilities, and even within facilities, you have to have a 10-bed plus unit before they start to look at some of those standards. I just received an email a couple of weeks ago that they are now looking at developing standards for the community part of the care as well too, which is great, and I offered to help with that as well. So again, we need the national standards to measure things by. So again, a lot of the questions that come up are hard to answer because there aren't the national standards that need to be there. And we've been working on for years national indicators and just deciding on what are the specific indicators that we need to be measuring that, one, are going to be beneficial to the patients and families because they truly will carry that kind of information and weight, as opposed to just indicators that are going to show that, yeah, you're worth your weight in salt kind of thing.
So then it would be collecting research and data on palliative care. That's valid in and of itself. And then you would look for another clause to develop national care standards or national care standards and quality indicators.
Yep, exactly.
For improvement.
Sorry, if I may say, I don't know what they mean by collecting research. I would say it's encouraging research and collecting data. Or stimulating research.
Promoting research.
Promoting research, yeah.
And collecting data.
Yeah.
Scott, thank you very much. That's all I had, Mr. Chair. Thank you.
All right, that completes our session. And I want to point out to the members of the committee that Dr. Henderson was scheduled for Tuesday, and he spent Tuesday at the airport in Halifax. He called me just before the committee and said that he was in between canceled flights and couldn't get here. So he spent that day for the committee, but not at the committees, and here you are again today. So I appreciate your commitment, and I know you've been long-term devoted to palliative care, and it won't fall off the table as long as Ms. Gladue is here, I can assure you that. And Dr. Chasen, you know, it's interesting, you're from South Africa, and one of our other witnesses yesterday had roots in South Africa as well, so I don't know what the South African influence is, but it's interesting. But anyway, we very much appreciate your contribution and been very helpful to us, but I think we're making significant headway here. Go on.
One comment, which I'd like to offer to this committee. Palliative care is a complex entity, as I'm sure you're gathering. You know, it crosses hospital, acute care, community, long-term care, homeless people, everywhere, rural, urban. And it's so diverse, includes spirituality and so on. It's very diverse. Pallium has a module called LEAP, Taking Ownership. It's under LEAP Core. It's a 1-hour module that I will offer that if you as a group would like to get, again, a 101 palliative care, it's appropriate for people who aren't physicians. We've provided that. It's part of the LEAP core presentation that we give to nurses, physicians, social workers, pharmacists, and so on. But it gives you a good perspective of what it is we talk about, and I think it would give a better understanding of palliative care in general. So I'll throw that out there as an offer. You know, I would be happy to make myself available anytime if you want to do that, just to try to help give a better foundation if you felt you needed something like that.
We'll discuss that, but thank you very much. Now, we have a little bit of committee business we have to do. If we, I'll do it as quickly as we can, but we have all-party agreement, I think, on changing the schedule for the next meeting is going to be clause by clause. So that's settled, and the meeting after that will be on M47, meeting on May 23rd, or March 23rd. And also, would somebody move an adoption of the budget for the Bill C-277 to help pay our witnesses? Moved by Dr. Carey. All in favor? Approved. Okay. Motion. And thanks. Yes. Pardon? Oh yeah. Just before we leave, one last thing. We need to adopt the work plan for M47. Everybody has a copy of it. Do I have a motion to adopt the work plan for M47? Thank you, Mr. Veerson. All in favor of the work plan for M47? Motion passed. Okay. That's it. Meeting adjourned.